to pop your camera back on afterwards once you consent to the recording, and then we'll get going. So you just have to accept the recording, Katie and Catherine, and then you should be able to turn your camera back on. Great. Okay, Claire, can I get you to share our slide deck with everyone? Okay, perfect. Great. All right. So welcome, everyone. My name is Rachel Jackman-Tonio. I'm the Knowledge Translation Coordinator with the Maritime Spore Support Unit, or MSSU, and I'm your host this afternoon. If you're not familiar with the MSSU, we're one of 11 spore support units across Canada that support and conduct patient-oriented research, and we work in all 3 maritime provinces. I'd like to start by offering a land acknowledgement that reflects my location. I'm in Chibuktuk, or Halifax. I want to acknowledge that I'm in the lands of the ancestral and unceded territory of the Mi'kmaq people. This territory is covered by the Treaties of Peace and Friendship, which Mi'kmaq and Wolastoqiyik people first signed with the British Crown in 1725. We are all treaty people. We also recognize the histories, contributions, and legacies of the African Nova Scotian people who have been here for the last 400 years. And some of you may be joining from other parts of the country, so I'd also like to invite you to add a land acknowledgement to the chat, sharing the lands where you live and learn. Now, before we dive in, a few housekeeping notes. I think a lot of these will be familiar, and I'd had a note about saying we're switching from Zooms to Teams, and hopefully we won't have too many hiccups, but I think that ship has sailed. We've had hiccups, but we'll carry on. A couple of things to keep in mind. Please mute your microphone. As I mentioned earlier, we are recording this session, so the recording will be available on the MSSU website afterwards. Live captions can be turned on in your Microsoft Teams settings if you'd like captions. And if you have questions at any point, feel free to type them in the chat and we'll come back to them later in a question and answer period. Okay, so Claire, if you move us forward. What brings us here today? So we're going to be talking about learning health systems. And I think this term, or LHS, if you heard the acronym, can be a bit confusing or maybe new to some of you. So I wanted to start with a quick definition. This one is from the Agency for Healthcare Research and Quality. They point out that in a learning health system, internal data and experience are systematically integrated with external evidence, and that knowledge is put into practice. As a result, patients get higher quality, safer, more efficient care, and healthcare delivery organizations become better places to work. Now, there isn't really a single definition or model of LHSs, but really at their heart, they sort of share this core focus on generating, integrating, and applying evidence in healthcare in a continuous process to really improve outcomes for both patients, providers, and the broader health system. And as a result, I'll just get you, Claire, to move forward a slide for me. Learning health systems are often visualized as a learning cycle, and this is ours, the graphics on the website, if you're curious to know more. But in these cycles, you can see that there's the various components that feed into each other. So data is generated, it's integrated with external evidence, studied to generate new knowledge, and then used to improve policy, practice, and inform decision-making. And then the cycle continues. Given our patient-oriented research work, we put communities at the heart of this learning process and reflect our values and health system aims with an overarching commitment to equitable healthcare. And it's a very flexible model, and you may recognize aspects of your own work in an LHS approach, even if it's else. And that's what the series is all about, sort of getting to know with this cycle. And so today we're going to zoom in. Claire, you can go to the next slide, and really at how can policy and practice dig into implementing evidence-based changes in learning health systems. And I'm going to keep the introductions short so that our speakers have as much time as possible for their presentations. But you'll be hearing from Dr. Katie Burney, a clinical psychologist and associate professor at the University of Calgary. She's going to introduce the first ever national standard for pediatric pain care in Canada, and Patty Douglas, a clinical implementation specialist in pediatric pain management with IWK and Solution for Kids in Pain, SKIP, is going to be sharing insights about how that standard is getting applied collaboratively in Nova Scotia. We're aiming to cover all that ground in 30 minutes or so, which should leave us some time for Q&A at the end. So with further ado, I'll pass things over to Katie to get us started.
Awesome. Thank you so much, Rachel. And just want to say thanks to you and to MSSU for the invitation. And just also huge thanks to Patty for co-presenting today with me. I think it'll help bring today's session really to life in a concrete way. So really grateful to both of you and to the broader group. And exciting to see some familiar names as well as some folks I don't know. So looking forward to today's discussion. Next slide, please. So I'll just start with my own land acknowledgement. So I'm SKIP's Associate Scientific Director. SKIP is a national network, but based at the University of Calgary and the Children's Hospital here in Calgary, which is the traditional territories of the people of Treaty 7 region of southern Alberta, which includes the Blackfoot Confederacy, comprising of the Kainai, Piikani, and Siksika First Nations, as well as the Tsuut'ina Nation and the Stoney First Nations. And it's the home to Métis Nation of Alberta, actually districts 5 and 6. Next slide. So many of you will already know that pain in children matters, but just to ground us all in what we do know about children's pain and why we're having this conversation today, it's ubiquitous to all areas of child health. So when children will deal with chronic pain or pain that lasts at least 3 months or longer before they reach adulthood, from a myriad of means. And pain is very common in hospitalized children in particular. So data from hospitalized children experience 6 painful procedures in the past 4 hours, with as many as 14 procedures for those in the neonatal intensive care unit. So it's very common. And that doesn't include all of the pain experiences that may be common for generally healthy children, such as vaccines otherwise. Pediatric pain has short and immediate and long-term consequences. There's an abundance of research evidence talking about how early pain experiences influence brain development, pain sensitization, socio-emotional development, also can contribute to healthcare avoidance that lasts later in life as well. And of course, chronic pain can have a huge impact across many areas of life, school functioning, friends, family, health and physical well-being. So really it's a wide, highly impactful challenge. And it's something that can have an impact across the lifespan. So pain in children, particularly chronic pain, has been linked to persisting pain into adulthood, mental health problems in adulthood, substance use, and also socioeconomic disparities to adulthood as well. So it's really emphasizing we need to do a quality job in childhood to set people up for life. Data suggests that it has huge direct and indirect costs for families and for society in Canada. And there's also a lot of work suggesting that when we prioritize pain and we manage pain well, that can support healthcare work and also retention. And I think things that are pressing issues for our healthcare workforce as well. And lastly, but of course not least, it's a human right. So this is something we should be doing regardless. And we really need to pay attention to it because pain disproportionately impacts a number of populations, including nonverbal youth, queer youth, Black youth, and also Indigenous youth and their families. So really emphasizing the need to have an equity-oriented lens to our work as well. Next slide. Yeah, and Canada is actually a world leader in children's pain research. So data suggests that per capita, we kind of hit above our weight in producing a lot of research knowledge about children's pain. But much of this isn't actually reaching children and families every day. So we really need to make sure that we're finding ways not just to produce research knowledge and evidence about how to manage children's pain well, but that we're actually making tools, resources, and strategies available. So they're really embedded within our health systems and our society to improve pain care for kids. Next slide. So this is where SKIP comes in. So Solutions for Kids in Pain is a national knowledge mobilization network. on a mission to improve children's pain by mobilizing evidence-based solutions through coordination and collaboration. In particular, on this call, folks might be interested that SCIP is based at Dalhousie University, but does, of course, have this national reach and focus and engagement of hubs and folks like Patty in many places across the country. And of course, we don't do any of this work alone. SCIP's approach is to meet people where they're at, and we do that through heavily engaging in partnerships with others to go where people already are, to learn and to share resources and tools and strategies for quality pain care. Next slide. So I had the privilege in my role with SCIP to partner closely with the Health Standards Organization and develop the world's first national health standard for for pediatric pain care. This is the first national health standard for pediatric pain in the world, and it's actually a place where we've been able to lead in the child health space. So there is no current national health standard for pain in adults either. So we're really the first out of the gate to prioritize quality pain care. The scope of the health standard is all hospital settings that serve infants, children, and adolescents from birth to 19 years less one day and their families, including inpatient, outpatient, emergency, and diagnostic services. And critically, I think for today's conversation, when I say all hospital settings, I really mean that. So it doesn't just mean children's hospitals or tertiary care hospitals or rehabilitation hospitals. The standard is also relevant and includes community regional hospitals, where maybe children and youth are only a slice of the population that the hospital seeks to support. Next slide. Number of key systemic drivers that you may be aware of. So for the first time in 2018, the World Health Organization's International Classification of Disease, the most recent version, ICD-11, for the first time identified chronic pain as its own disease, identified as chronic primary pain. So that's been a big shift based on research evidence and really starting to translate some of that into care. In 2019, the Government of Canada struck a Canadian Pain Task Force to really map out what was happening in pain care and pain policy in Canada, and then to culminate through 3 reports in a plan that was this task force came about this, and consequently a lot of advocacy from folks living with pain as well as pain experts to really ensure that as society sought to address the opioid crisis, that it was not at the detriment of quality multimodal pain care. And we're very fortunate that one of the co-chairs of the Canadian Pain Task Force, Dr. Fiona Campbell, is a pediatric anesthesiologist and pain doc at SickKids. And so pediatrics and health was really well represented in this final action plan as well. And one of the 6 key recommendations was to ensure or strive towards consistent quality pain care for all folks living in Canada, regardless of where they live. And things like a health standard that we're talking about today were a key means for us to get there. The WHO also has published guidelines on chronic pain in children, and then also an international Lancet Child and Adolescent Health Commission in Pediatric Pain published in 2021 laid out 4 transformative goals for the field that you'll actually see reflected and embedded within the health standard. Next slide. This is an overview of the standard development process. I won't go into each in detail. I think some key pieces here are that it's an accredited, rigorous process that's mandated by the Standards Council of Canada in order to develop a national standard of Canada. And so after we went through this process of developing the standard with a working group, review of literature, expert opinion, and also a public review, and then revisions. The Standards Council of Canada independently reviewed documentation of our standard development process and did award us and identify the standard as a national standard of Canada because of that rigor. Next slide. So here's the sections of the health standard, and just to emphasize up front that the whole standard makes a commitment to a people-centered approach. And what this means for us in the standard is really also placing children and families at the center of that. They were key people in developing the standard alongside diverse multidisciplinary health professionals and administrators, but they're also defined as key members of the health team in the health standard alongside health professionals and others. The standard itself has 34 criteria over 6 sections, and these initial titles, Make Pain Better, Make Pain Understood, Make Pain Visible, and Make Pain Matter, were the 4 transformative goals that came from that Lancet Child and Adolescent Health Commission. The first section of the standard really targets organizational leaders within hospitals about the supports, strategies, actions they need to take to make sure that the policies, the infrastructure, the systems, the processes, and resources are in place for health professionals and healthcare teams to actually deliver quality pain care. And I think this is a really key part that differentiates a health standard from a clinical practice guideline. So it doesn't just address what health professionals should do, but it really also targets some of that systemic structural aspects that need to be in place to enable them to deliver that care. The second section focuses on professional development and education to create a knowledgeable and confident workforce and provide some specifics around core competencies that all within the healthcare workforce within a hospital, not just the health professionals, but all staff should have about children's pain, and differentiates that from specialized competencies that those who are working in areas where pain is very common or on specialized pain teams may need to additionally know. The third section focuses on pain assessment and reassessment, what should be part of that, thinking well beyond how intense or severe pain is to how pain impacts the whole child. Because we know that's the case. And I did mention, you can see here, equity, diversity, inclusion, and accessibility are embedded throughout the standard, which includes some of those marginalized communities, racialized communities, and as well as nonverbal youth in particular. And this really comes out in this pain assessment aspect with regards to how do we support nonverbal youth to also be able to communicate their pain to the maximal extent possible, or consider kind of observations for those youth. The fourth section focuses on co-developing individualized pain care plans with an eye not just towards working carefully with the child and family in that, but also considerations around transitions in care as key places where quality pain care needs to continue and can fall down. The fifth section digs into multimodal pain management strategies, separating acute and chronic pain management, and really emphasizing not just pharmacological interventions that are recommended, but also physical strategies and psychosocial strategies, including traditional medicines, a key piece for Indigenous children and their communities in the delivery of quality pain care. And there are a few criteria specific to opioids there as well. The last section is really focused on continuous quality improvement with criteria for organizational leaders and healthcare teams about that. And a key piece in that one I'll highlight is identifying untreated, preventable, undermanaged pain as a patient safety incident and providing some direction around that. Next slide. An overview that the standard really emphasizes quality pain care and equitable pain care for youth. And here's how we define those. We define quality pediatric pain care as care that's accessible, consistent, equitable, evidence-informed, individualized, multimodal, and safe and effective. So equity is part of quality care, but we further define equitable care as care that's anti-oppressive, anti-racist, anti-ableist, culturally informed, individually tailored, and trauma and violence informed. Next slide. The goal is to enhance service excellence and continuous improvement and offer that direction to organizational leaders and teams. And we're continuing to work with Accreditation Canada, who's a partner organization with the Health Standards Organization, to make the standard available as an assessment standard so that hospitals can self-assess or potentially be assessed externally against it. Next slide. This is not to go over the content in this, but just to give you a snapshot of what the standard looks like. You can see there's criteria and then brief guidelines that support how organizational leaders or healthcare teams and hospitals can actually achieve that criteria. Next slide. Just more of that. So keep going. And just to share, there's been a lot of interest. SCIP's been working hard to build awareness about the standard, as well as supporting implementation through roles like Patty's, but otherwise too. We know as of June 30th, so just over 2 years since the standard was published, there's been incredible international interest, as well as national interest. So more than 2,500 downloads from 78 different countries around the world. And within Canada, it includes all the provinces and 2 of the territories. Next slide. So if you haven't accessed it, you should. Many of these standards are typically at a cost to download, but through our partnership with HSO, it's freely available in both English and in French. So downloading that directly from HSO's website. And SCIP has also developed an executive summary in both English and in French to support communication about that more succinctly with others too. Next slide. Very, very briefly, because this is where I want you to be able to dig into Patty's stuff. SCIP nationally continues to work to support direct implementation. So beyond just building awareness, many presentations, consultations, new partnerships, especially reaching beyond those children's hospitals. We've worked formally with partners as well as on our own to assess barriers and enablers to implementation, hearing from health professionals, hospital leaders and managers, as well as patients and families themselves. We're working to develop new tools and resources all the time for all of those audiences, including right now an interactive, will be publicly available online implementation guide for hospitals, which runs you through the steps to support implementation of the health standard, but also links you to many more evidence-based resources that we were not able to link in the standard to bring it to life. We're continuing to seek funding, having secured a couple of different funds over the last few years, focus on supporting the health standard implementation, including one we have right now, a national project funded through the Kids Brain Health Network, with an eye specifically towards children with neurodevelopmental disabilities. And of course, we continue to partner with HSO and Accreditation Canada to continue to move this forward as formal hospital assessment. Next slide. Feel free to stay in touch with SCIP more generally if you aren't already connected. And with that, I'll just say thanks and turn it to Patty.
Great. Hello, everyone. Thank you, Katie, Rachel, and MSSU team for having me join today. I am located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people, and we acknowledge them as the past, present, and future caretakers of this land here at IWK Health. Now that Dr. Burney has provided an overview of the pediatric pain standard, I will take you through the implementation process that we have been working on across the Maritimes, reviewing the strategies and the planning process that has been enabling our team to incorporate the standard into practice. Next slide, please. IWK Health is viewed as the primary hub for pediatric healthcare across the Maritimes. We have built partnerships with healthcare institutions and organizations like Solutions for Kids in Pain, also known as SCIP. When preparing to implement and disseminate the national standard on pediatric pain, the team at SCIP wanted to prioritize the community. SCIP saw the need for proper implementation of the national standard by creating the position of Clinical Implementation Specialist in Pediatric Pain Management in partnership with IWK Health's new program, Maritime Child Health. This program, Maritime Child Health, is a 5-year, fully donor-funded program that uses a learning health system approach to bring equitable pediatric care closer to home. The position was created in a unique partnership to solely focus on pain care and its management. I now hold this position. I'm a registered nurse by trade and have worked in a variety of roles, both as a bedside nurse and in education and leadership. My career started in rural Nova Scotia and led me here to the IWK, which really allowed me to gain an appreciation of the needs and resources across the province. I have been a frontline care provider for both medical and surgical patients along with their families. Now in this role, I can share this work across the Maritimes and really collaborate with these regional sites as champions for pediatric pain and ensuring that we can build on current practices. This means connecting what is in the research to what is happening on the front lines by reviewing practices, evaluating strategies, and planning for sustainability with policy creation. The national standard was released to help guide care and ensure quality improvement in relation to pain. We know for children to be healthy and well, it is critical that they receive quality pain management at every encounter with the health system. Pain care directly impacts a person's well-being. Not having pain effectively managed and treated can be detrimental to their health outcomes. We also know that research takes an average of 17 years to change evidence, or for evidence to change into practice. With this new unique role and following implementation science, we want to ensure that by using a learning health system approach, we enable a cycle of rapid learning and improvements, including mobilizing evidence-based pain knowledge and sustaining it in practice. Next slide, please. So Maritime Child Health is a pediatric learning health system that really strives to ensure children from across the Maritimes can access equitable care close to their own homes within their own communities. With this being the focus, we are working to bring education and increased comfort for those healthcare providers who work with children across the region. The regional sites have healthcare providers doing pediatric work every day and are voicing their want to increase education. They want to build their own capacity to reduce the need for relocation of pediatric care. When building the framework for maritime child health, we chose a wheel that is ever evolving, keeping our children, youth, their families, community partners, and healthcare providers at the center of the wheel. The learning health system cycle is embedded within this wheel. Data, knowledge, policy, and practice are leading pillars to knowledge mobilization and continuous quality improvement, similar to those of MSSU. We want to ensure quality healthcare encounters are happening across the region and not just at the hub. For pain care, a quality healthcare encounter does not start until pain is properly assessed and addressed, using a person-centered approach, as in the standard. Involving patients and their families is crucial, since they are the experts on their own children and their lived experiences. This truly encompasses the framework built to implement this work here at Maritime Child Health. This will bring pediatric care across the Maritimes together to share experiences and ensure that no matter where a family seeks care or encounters the healthcare system, pain care will be integrated at all stages. We plan to continue utilizing the national standard and, of course, SCIP's expansive network to help guide this implementation approach with the learning health system lens. Next slide, please. So the role was the first of its kind in Canada. Several children's hospitals, such as Sick Kids and Stollery's Children's, are now following suit and creating similar roles to ours to ensure the implementation of the pediatric pain standard is seamless and done with thought and care. As we implement the standard, we are focusing on our partnerships and working together to ensure we utilize the available resources that integrate that knowledge into practice. We have national partnerships with children's hospitals across Canada, working with the groups to ensure we are on the same track, benchmarking with one another, and not reinventing the wheel for every pain-related initiative. As Katie mentioned, Kids Brain Health Network, for example, is leading a grant-funded project for kids with neurodevelopmental disabilities to help them achieve their full potential. IWK Health is a part of this project, which enables us to collaborate with other organizations across Canada to create virtual resources and complete environmental scans of the current landscape. Once the projects are complete, IWK Health and our regional sites will have access to resources and supports that are developed across the project. Aid and accessibility for more patients and healthcare providers to benefit from IWK Health also received an international designation last spring. Using that designation and our position as a tertiary care center allows us to continually ensure quality improvement and be leaders in pain care. The designation shows our commitment to children's comfort and brings a structured process to evaluate current practices and gain valuable assistance in key areas needing improvement from recognized experts in the field of pain management. The 4 regional health networks, Nova Scotia Health, Health PI, Vitalite, and Horizon Health, have been eager to build on their current practices, ensure that they not only meet but exceed the national standard on pain. This involves connecting with SCIP, Children's Healthcare Canada, and other children's centers across the country to perform a gap analysis, expedite knowledge translation, and build a system to ensure accessibility and connection for all. I will expand a little bit more on that and how we're partnering with these regional sites in the coming slides. Next, please. So pediatric pain has a relevance across many areas in healthcare settings, as Katie had mentioned. Knowing this, we have opted to implement and connect with partners in a phased approach. Our initial phase has been ongoing. We are working with 6 pilot sites across the Maritimes. Our pilot sites include separate pediatric units, those with women's and children's units with mixed care, and those that may provide ambulatory or procedural care to pediatric patients on a regular basis. This phase began with pre-work, building a gap analysis for each individual site. I will speak more on that in the coming slide as well. Choosing sites with diversity helps give an overview of practices across these regional locations. Following the pre-work phase, we move into phase 1, stage 2, and work with the sites to share resources, implement policy and procedures, and build on current practices to adhere to the standard. This has included site visits and building connections with those providers that are working on the front lines. After that, we are creating implementation plans that are individualized and dependent on the results of the site visits and gap analysis for the local context. In phase 2, with the spread and scale, we will be spreading these plans to the remaining hospitals and health centers across the Maritimes that are providing inpatient, pediatric, and ambulatory care. Pulling from those initial implementation plans, we can then broaden our focus and pull from common themes and gaps to help the remaining healthcare centers. By using a more generalized approach and assessing those commonalities from the pilot sites, we can address gaps and ensure the secondary sites are able to be guided through implementing all criterion from the standard. During the next phase, we'll focus on emergency departments, outpatient blood labs, and diagnostic imaging across the Maritimes. This will include many sites involved in the initial phase and also independent sites. We will utilize our partnerships with the team at TREC, which stands for Translating Emergency Knowledge for Kids, and our regional educators and leadership groups to ensure a collaborative approach. And in phase 4, we would be looking to share and expand into the community with an approach that reaches primary care and public health. We have already been working to introduce themes and initiate those building blocks with our primary care providers. Even though this is a phased approach, we are actively taking on opportunities as they present themselves to build awareness and interest for future audiences. This will lead to some overlap in phases as we move along our implementation plan. Next slide, please. A gap analysis is a strategic process that identifies the differences between the current state and desired future state of a health institution. By compiling this information, it allows for the creation of an action plan to bridge those potential gaps. In this context, it involves a comparison of the actual state of pain care with alignment for the pediatric pain standard. This gap analysis serves as a method to identify areas of improvement, standard processes, or expansion of resources, effectively providing a data-driven foundation for future strategic planning and quality improvement is helping us reach our objectives of implementation. To gain a full picture of what practices the site currently have and to build an informative picture, I start by reaching out to leaders on the pilot sites to have conversations surrounding pain care. I have broken down the standard criterion into questions to gain an understanding of current practices and policies. The gap analysis was conducted using qualitative discussions with the local teams, validating the current practices, understanding their infrastructure and staffing requirements, followed by resource sharing to meet the standard criterion. For example, when looking at criterion 1.1.6, which states, the organizational leaders provide teams with access to validated tools and pain assessment to inform individualized care plans for all children and communities served by the organization. I start by asking the staff to tell me examples of assessment tools they use when assessing pain. To further that, I ask, how does your choice of tools change when caring for an infant versus adolescents or a child with neurodevelopmental disabilities, as well as reviewing the policy and procedures the organization may have available to their staff. For criterion 2.1, it states the organization establishes an evidence-informed education curriculum for pain management. This had me reviewing and exploring the educational systems and modules related to pain care that IWK and Nova Scotia Health offer their staff. Following that initial discovery phase, I then discussed pain care involvement in staff orientation with the educators, and then during our site visit, I learned more as we conduct focus groups with the frontline care providers. Creating focus groups to inform the gap analysis has actually been one of the best data gathering methods in this approach. In the gap analysis phase, I can see a full picture by building relationships and having those connections with the sites. In our focus groups, it has been ensuring conversations are non-judgmental, emphasizing strengths and idea sharing in an open conversation. By using this strengths-based approach, it has allowed for knowledge sharing. The groups are understanding that during implementation, we're not forcing change, but instead building on their current practices to ensure all children have pain care provided at every healthcare encounter to improve overall health and well-being. Next slide. So our present work, I took on this position in May of this year, and I've been working over the last 4 months on assessment planning and building connections. As well, our Maritime Child Health and SCIP teams have been participating in furthering education on knowledge mobilization and implementation planning. It is important for us to keep up with best practices in the field as we spread and shape care. Other work has involved reaching out to our pilot sites and allowing them to identify what they feel their strengths and opportunities for growth are. In conversations with the leadership teams that include management and educators, I can start to identify potential barriers and facilitators. I have been meeting with regional and community sites and finding out their goals for education to tailor presentations and resource sharing to the specific needs of the community providers. Implementing the standard involves providing education on the standard as well as resource sharing and bridging gaps when we identify barriers within the institutions. For example, with Cape Breton Regional Hospital, they have completed their gap analysis, and this worked by completing a site visit that included both decision makers and frontline care providers, such as nurses, admin, and child life specialist. After the site visit, I've been able to build an implementation plan as I review their gap analysis results. The QEH on PEI is another pilot site currently in the pre-assessment stage. I have met with their leadership team to start tailoring education to what they feel are the current barriers preparing for their site visit at the end of September. And later this week, our team will be doing a site visit at Yarmouth Regional Hospital to hear from the frontline staff and complete the narrative portion of their gap analysis. During that site visit, I will also delve into current practices and assess resource contexts such as infrastructure, staffing, unit needs, and more. Next slide, please. As we continue with the pilot sites, I've been exploring regional context as well. This involves identifying and analyzing the interconnected infrastructure, practices, culture, and policy factors that influence an organization with a specific geographic area. It's crucial because no community exists in isolation, and these determinants can aid or delay knowledge translation into practice. During the site visits, I have gained some great insight on the available resources and existing infrastructure on these regional sites. Some have access to sensory spaces and treatment rooms, while others have child life specialists available where that has been a barrier for other locations. When it comes to procedural pain, this can be essential in planning and reduction of pain. Knowing where an inpatient or ambulatory care unit lacks or exceeds in their resources enables our team to ensure we are connecting them to appropriate strategies to improve pain care. At IWK Health, we're fortunate to have a skilled team of child life specialists to work with and learn from. This group is also willing to share their expertise and aid in empowering nursing staff and care team staff to have tools of distraction, positive language, and also an understanding that preparation is a necessary tool prior to any procedure. Taking the time to prepare a child reduces future trauma and increases the likelihood that they will seek preventative care in the future. This has been seen for immunizations where pain has been properly managed. Research has shown those individuals are more likely to seek health promotional activities than those who had no pain management during routine immunizations. SCIP and Maritime Child Health want to focus on the community health care providers and building their capacity to provide care across the Maritimes. We are seeing on an ongoing basis that there are continued gaps in assessment and treatment in pediatric pain. SCIP works with patient providers and partners to hear their voices, and in the implementation plans we are building in the importance and need for children and their families to be given a voice. We also acknowledge through patient experience teams, reports of moral distress from providers, and patient and family feedback that some areas are lacking in children's pain care. To meet the need of our communities, we are working with a local community organization, People in Pain Network, and researchers at a number of Nova Scotia universities to understand the barriers and factors that contribute to inequitable pain prevention, mismanagement, and undertreatment of children's pain. We want to focus on chronic pain and improve their experiences where patients have felt unheard or dismissed in healthcare settings. Next slide, please. So knowing the standard covers a wide range of pain care needs, it was necessary to gather data in a mixed methods approach. Following the site visits, I have numerous types of data to compile. Data collection is happening using a mixed method approach, including verbal and digital surveys, focus groups, and follow-up discussions. Gathering this quantitative information from surveys and focus groups is a process that is evolving with each site visit. I use Excel and a survey system to compile the information the sites have shared and analyze the data using content analysis and descriptive statistics. As we move through the pilot sites and grow the work, we will be able to see the impact these education sessions have and the resources Maritime Child Health and SCIP provide may be adjusted. We currently have a pre-implementation survey and a compiled data based on the HSO pain management standard criteria as mentioned above. We are working on follow-up survey methods to assess the impact of education without causing survey fatigue. Following the data gathering phase, we create a qualitative content analysis, pulling broad themes along with unique sub-themes that reflect to each pilot site's local context. As we work through the 6 pilot sites, using these results and analyzing the content will lead to future project work for the sites along with quality improvement and the need for knowledge mobilization on the front lines. Next slide, please. So we have also been working on building engagement across the region, and this is happening especially in these ways. First, here at the IWK, we have a group of diverse healthcare professionals known as Pain Champions. We are expanding our team to include members beyond IWK Health. By inviting our regional partners, we are gaining a greater perspective to increase inclusivity across the Maritimes. Pain Champions collaborate with the IWK Child Kind Steering Committee, Maritime Child Health, and SCIP, and they review practices related to pain management and provide guidance to clinical staff on how to implement strategies and work, and review institutional resources and policies, and also documents related to pain management. As well as we collaborate monthly, receiving education from experts in our field of pain care. Secondly, our Maritime Child Health team has been working on monthly newsletters. You can access the QR code to sign up for it here. They will be on a variety of topics related to pediatric care. Looking ahead, we will also have one specifically related to pain care and implementation of these topics. And next, SCIP's website has a variety of tools and resources. It also has a monthly newsletter in the loop that you can help that can help you keep in the loop when it comes to pain care and implementation work. Katie shared in her previous slide, so please visit our website. Next slide, please. With that being said, implementing the national standard for pediatric pain management is not an easy feat, but with our learning health system pulling from research and pushing to understand the local context, we continue to move forward and ensure that all children across the Maritimes have access to equitable care closer to their own homes. Using our learning health system framework allows us to continue to connect research into practice, mobilize knowledge, and ensure continuous quality improvement. With SCIP and Maritime Child Health, we are working together to ensure there is access and awareness for all healthcare providers and families to use the standard daily. Focusing on facilitators enables us to lay building blocks that are maintained across organizations by empowering frontline care providers in their abilities and increasing their comfort and capacity, no matter what the available resources may be. We will continue collaborating with community partners and regional sites in order to grow a network of passionate providers, which will allow for sustainability and integration of best practice. Positive outcomes are the effects of deliberate actions during the implementation process. Knowing that pain care is integrated into every aspect of health and well-being, we need to continue to take necessary steps and set manageable goals to break down those barriers and ensure implementation is successful. Pain care does not just happen in one setting, it happens in every healthcare encounter for all ages across the lifespan. By adhering to the national standard, we can ensure that pain has visibility, that it matters, it is understood, and subsequently made better from that knowledge. Next slide, please. So thank you for joining us today. You can connect further with these emails on the slide, and you can find Maritime Child Health and SCIP's teams linked through IWK's external website.
Great. Thank you so much, Patty and Katie, for the fantastic presentations. It's such a great example of learning health systems in action, and it strikes me that the national standard is in itself a huge accomplishment, but really just the starting block for how we make change and have an impact for children and youth and their families and healthcare providers in the system. And Patty, you so beautifully illustrated how the LHS approach and this continual collaborative learning process can help with that implementation piece. So I'd like to use what time we have left for questions. Thank you so much, despite the hiccups at the start, to everyone who's still here with us and to our speakers for rolling with things. We do have a few moments. A reminder, you can drop questions in the chat, or you can raise your hand if you'd like to come on camera and ask yourselves. While people are thinking of their questions and perhaps dropping them in, maybe I'll get us started. Patty, one of the things I found really interesting was how much collaborative learning is a part of this process. So you have this phased approach where you're working to understand the local context and how to implement there, but then also creating some connections between what's learned, the commonalities of pilot sites and future secondary sites. What do you kind of see as some next steps for continuing to grow that organizational culture around generating and applying evidence in practice?
Yeah, I think the next steps in order to continue that learning would be really incorporating new and diverse learning opportunities to leverage technology when it comes to sharing that information and ensuring that we're staying on top of the new best practices. Also making sure team leadership is continuing to reinforce that culture and allow for the time and supports in order for providers to build that capacity should really be the next step.
Fantastic. Katie, did you have anything you wanted to add around the culture piece?
Yeah, it's such a good one. And I think in the area of children's pain, we do face sometimes a need to address that culture aspect. I think pain is so common. It's something we've all experienced, and especially pain from something like medical procedures. It's amazing how easily those are dismissed. And I think, so I think it's an area, and often when you talk with families, yes, sometimes it's one procedure, right, that was particularly poorly managed and particularly traumatic, but sometimes it's the accumulation of many procedures, which an individual health professional sees, oh, it's just this, it's just kind of one prick, or it's just one blood draw. But from the youth and family perspective, it's actually an accumulation of things over time as well. And I think that speaks to the need to partner and the value of partnering and placing, as Patty showed kind of within the IWK learning health system approach or the maritime approach, placing children and families at the center of that. And I think that really speaks to it. And I think we still continue to face culture shifts with particular populations, and not to call the IWK out, but I did my PhD at the IWK, and one of my first projects, more than 10 years ago, was looking at pain care across the whole site and asking kids about
Oh,
their
wow.
pain care. And still at that time, there were folks who said, well, you don't need to talk to that kid. They have autism. And so I think that's something we need to still kind of keep front of mind is, just because a youth can't communicate something verbally, or just because there's something else like a neurodevelopmental disability going on, there's still culture and attitude shifts that we have to address. It's just one example, right? And I think we are making strides, but I think these are things that are not ill-intentioned, right? Like, just to be honest about that, I don't think people come ill-intentioned. I think people want to make sure that children are comfortable and get the best care, right? But I think, this is why all the efforts of the health standard, but also putting that into practice, is just supporting people to do that with the best available knowledge that we have.
And that was certainly a piece that came out too, Patty, and yours, that sort of strength-based approach, starting where you are, and then how can we build and use the standard as a tool to improve. I think that's a really excellent point about carrying that forward. And I see we have a question in the chat from Tori. They say, thank you very much. What amazing work. I'm so inspired. For the pain champions, do they have a recognition and compensation in their role for this work? They find it a challenge when finding champions, as people are often overworked and overstretched.
Yeah, absolutely. We don't have compensation for our pain champions. We are a group right now, about 95 providers across the health center. We have 4 new additions that are outside the health center, so that's very exciting. We have a range of nurses to physicians to child life specialists. So depending on their role and their position, they're able to use our meeting time, which we usually have an education portion, to take back and use it for continuing education or leadership points. For child life or for nursing, you get those points and you are able to put it towards your end of your union fees and goals. For child life, they're able to put it through their certification because they need to complete so much education every year. So they're able to put those points towards that. So depending on their discipline, they're able to really benefit from that. And we keep attendance and keep track of the education scenarios that we have each month.
Great, thanks, Patty. That actually kind of brings me to another question that I had, because I think those nuggets about how to make these things work within the sort of structures that are there, and how to sort of entice or incentivize some of these things. The presentation offered a lot of practical approaches like that. So you talked about breaking the standard down into guiding questions to facilitate conversations. I thought that was a really interesting way of taking the standard and putting it in that local context. And as I mentioned earlier, and you were talking about the strength-based approach, so really focusing on the facilitators and the gap analysis. And I think equally kind of working with what helps people in their particular roles around achieving their educational goals would be another one. Are there other pieces of advice that you would share with folks looking to implement practice changes, like a standard or a guideline? And Patty, maybe I'll hand that to you first.
Yeah. Really, I think the work with the gap analysis, really understanding what the current context is, really helps you get an overview of where to start and where to place those building blocks. A lot of the sites that I've been working with have been more open when I say, tell me what's happening now and how can we build off that, versus me coming in and being like, these are the things you need to do, or this is how IWK does it, so this is definitely the right way, which is not always the case. So we want to make sure that we're reassuring their capacity and reassuring what they're doing is also a great way to do it. As long as we're meeting the standard, it can be done in multiple ways. So definitely starting with an overview or an environmental scan of what is happening has really impacted that work.
Yeah, and creating the space for those conversations with people that understand from their perspectives. Katie, I saw you nodding there. Was there anything you'd like to add?
Yeah, I mean, I think one of the reasons in developing the standard in a target audience has also been some of those organizational leaders. So even though they aren't the ones necessarily doing the on the ground work to implement that change, it could certainly make a big difference to have their support and buy-in, whether it's to have a role like Patty's, whether it's to protect a part of someone's time, or whether it's just to have a leader champion across the site to elevate the work, right? That's happening, in an less resourced or less protected way. And, I think that was one of the many, I think, kind of advantages of something that's more at this institutional level is to because we know that, as Tori said, I think as Patty's talked about, there's a lot of people really working off the side of their desk to try to improve pain care and other aspects of care, right? And so I think pulling together your right team and taking a bit of time to cultivate those relationships and cultivate some of those I know we're using the word champions, but supporters, right? Who can really yeah, be along for the ride, and maybe that builds, right? Then that builds over time where they see momentum grow. So I think taking time to build those relationships is really valuable.
Yeah. Yeah, the momentum coming from the people and the involvement for sure. There's a couple of nice questions and comments popping up in the chat. I'm going to go kind of in the order they were posted. A really excellent point brought up by Heather. They say, do you see there being issues or concerns with children transitioning to adult care? Well, we still do not have standards of care for adult pain. And do you see opportunities for the children's services to work with the adult service to help with those transitions?
Yeah, I can maybe tackle that, and then Patty will turn it to you. So just to share, I think because of the success of the pediatric pain management standard, we now know that HSO has partnered to develop an adult pain standard as well, I think with a view to that lens across the lifespan. And just totally agree with Heather, it's an incredible gap, and I think barriers to how our health system is designed. And even starting right before that, this standard goes until 19 years less one day, but recognizing, I don't know if it's still true, but when I trained at the IBK, the emergency department age, and when transition happens is not at your 18th birthday, right? It can happen many times before that or after that, kind of depending on where care is happening. So I think, we're seeing momentum led from our pediatric healthcare space to support quality pain care across the lifespan. And I think some of, Patty's lens, and although the health standard is focused on hospitals, other work happening across the country more focused on primary care, and understanding that as that playing a role in supporting those transitions around pain care as well. So yeah, Patty, you probably have other comments, but it's certainly a gap and something that's critically important for sure.
Yes, transitioning is definitely a gap. We do work with our team here at Advocate Health with the transition team and trying to coordinate and best improve that gap. That was one of the work that we've been doing as well. I see that Cindy Brenniel is on the call with our local Nova Scotia universities and with the People in Pain Network Society with Virginia McIntyre. They are an adult-focused network and society, so really ensuring that we're figuring out how best treat children's pain, adolescents' pain. So when they transition into that adult health and work in their society and network, that they can really improve their care and pain from there. So we are seeing that gap as well and trying to improve that. With our pain champions, we're actually not just focused on pediatric patients either. Over the last 2 years, we've been able to expand our pain champions into our women's health in IWK. So we've had great work by one of our nurse practitioners in the women's gynae and gender diverse clinic as an outpatient area. They've been real champions in getting pain care to our women's health and now expanding more to our birth unit and our postpartum area. So we are a diverse group with both children and women and trying to really enforce that we're not just focused on infants and babies, but throughout the lifespan.
Just one more comment to Rachel. I think the inclusion of community regional hospitals in this health standard creates additional, like within that, it became maternal health, yes, and all those things. But I think, when we're prioritizing pain and including kind of settings where adults are also being cared for, it's a great example of how that can build momentum and kind of permeate. Right? Where people say, "Oh, that we might need more of that too," right? And many of the strategies we use in our pediatric environments are also super appropriate, for adult care as well. So yeah, I think those intersections are great.
Yep, and we're definitely seeing that kind of interest happening in the chat. So just Katie and Patty, I'll direct you to the chat. Tori has some interest in connecting with you. They're also working on a gap analysis, so lots of opportunity to learn from each other there, as well as some interest in how to become a pain champion. So hopefully there's some more connections and momentum building today through the session. We're coming up on time. So I just open the floor a little bit to either of you, Patty or Katie, if you have any final thoughts you'd like to share with the group. Oh, and Patty's put some contacts in there, so if people want to follow up there in the chat. We also will send around, I will drop just while everyone's still here. We do a quick evaluation survey from the session. It's very helpful to us in our planning. If you fill that out, it's just a few questions. And we'll also send it around in a follow-up email. So I'll put those contacts in the follow-up email as well as the links to the health standard and so on, just so people can build on the connections that were made here today. And with that, any final thoughts, Katie and Patty?
No, I mean, so much we could continue to talk about that. I think implementation is complex, right? Learning health systems are complex to bring to life, and I'm excited about kind of the work and even learned more as we heard from Patty today too. And there's lots of folks across the country, and not just in pediatric pain, right, where there's lots of synergy. I think pediatric pain we sometimes relegate as a niche topic, but it shows up in mental health. It shows up in all primary care, all other areas. So I think where we can work together with the same vision of kind of safe, effective, quality, equitable care and learn from each other, there's huge benefit. So thanks for the invitation, and it was great.
Thanks for being here.
Really echoing Katie. Thank you for having us, and we're happy to share our work, and we're hoping to expand on it and really improve pain care throughout the Maritimes and with our national partnerships as well.
Yeah. And on that note of gratitude, thank you both for being part of the session. I think it was a wonderful way to kick off the series this year, and such great work happening to learn from. There was one last question in the chat around the presentation. The recording will be available online. Oh, I see that Claire, my colleague, has dropped the link in the chat, and we'll include that in the follow-up email as well. So nothing left to do but say thank you to both of our speakers, Katie and Patty, and to all of you who made it past the hiccups with Microsoft Team links and so on, and were able to join us. Really great session. Thanks again. Okay, bye everyone.
Bye.